We'll run this seminar style. I love how the first two rows are still avoided. What's that? It's good for the camera. Wonderful. All right. So, any questions as to what we've covered so far? Any burning, deep-seated questions? You guys are a quiet crowd. I don't know whether to feel happy about that or a little bit nervous. Happy. You're experts on antihypertensive therapy, acute coronary syndrome, and complications to acute coronary syndrome. This is what makes me nervous. Silence. All right, so this material is building up on each other. So you're going to see now that we're getting into heart failure, we're going to be using what we've learned to keep diving forward. So, what's the most common cause of heart failure? Heart failure is the most common cause of heart failure? Left-sided heart failure is the most common cause of right-sided heart failure. What's the most common cause? So coronary artery disease, what does that mean? Plaque. Stable angina, that's coronary artery disease. Atherosclerosis. What's MI? Yeah, what is that? What is myocardial? What does that even mean? Okay, so you're getting closer. It's funny because now that you're going into the pathophysiology, things like heart failure, MI, they're really meaningless when you're starting to look at the path, right? If I were to give you an example, if I were to give you a choice, would you rather have unstable angina, non-ST elevation MI, or ST elevation MI? What would you want for yourself? Yeah, at least unstable angina, right? It'll probably be non-ST elevation MI if you check a troponin. But would you want a STEMI? No. Is STEMI an MI? Is a non-STEMI an MI? Is unstable angina an MI? It is. Plaque rupture. It's plaque rupture. You have plaque rupture. You don't know because it's a clinical diagnosis, right? If I give you a clinical scenario without a troponin and without an ECG, you don't know. That's the key for unstable angina. The funny thing is that the old troponin assays were very non-specific. We have first generation troponin, second generation troponin, third generation troponin. Now we're in our fifth generation troponin, super sensitive for myocardial injury. There's this debate that should we even get rid of the term unstable angina. Because any true unstable angina, clinically, you're going to rule in with these fifth generation troponins. We still teach it because at this stage of your training, you have to know the clinical diagnosis. And unstable angina is a great way to point out to you that if you are beginning to think of plaque rupture, it's a clinical diagnosis until you confirm with diagnostic testing. Does that make sense? So when you talk to your family members over break, MI, go ahead. Heart failure, go ahead. But in the clinical realm, the medical realm, these are not relevant terms anymore. Not to get philosophical on you, but the most common cause of heart failure is not MI, because MI isn't even a real medical term. Be more specific. From what? Plaque? Plaque rupture. Plaque rupture. Huh? Simple as that. You have atherosclerosis, which is plaque. It ruptures, causes myocardial necrosis, causes loss of left ventricular function, which causes heart failure with reduced ejection fraction. This is why we talk about plaque rupture first, then the complications to plaque rupture, papillary muscle rupture, VSD, LV aneurysm, pseudoaneurysm. The reality is even these complications are getting less and less frequent. Why? You're from LA, downtown LA. You're tripping over emergency rooms and healthcare centers. Yeah, Manhattan. ERs, dime a dozen. Every block there's a new ER or an urgent care center. Someone's going to do an EKG and then boom, down the block with a facility that has a cath lab. So late presentations are becoming more and more rare. That's not to say they don't happen. Where I am, I'm 90 minutes east of Manhattan. If you go to Fire Island, Shelter Island, sure, we see late complications. If you're in rural Midwest, sure, you see them. But the time to diagnosis and accessibility to the cath lab has made complications less frequent than in the past. With that being said, all of the complications that we talked about yesterday, by far and away, pale in comparison to heart failure with reduced ejection fraction. When you lose myocardial viability, infarction, necrosis, you lose left ventricular function. And that comes with a very extensive pathophysiology that we try to counterbalance with medical therapy. Okay? That's the outline of the talk today. So, we're going to define heart failure, understand the pathophysiology and epidemiology, understand the cellular basis, describe the various etiologies of heart failure, identify the underlying pathology, review the clinical signs and symptoms, and learn how to describe the clinical stages. There is no better way to discuss this than to dive into a real case. 50-year-old guy comes in with coronary disease. He's got a revascularized in the past with a drug-eluting stent to the LAD in 2007. It was complicated by a left ventricular thrombus on Coumadin in the past. What's Coumadin? Warfarin. What is it? Yeah, it's one of the classic blood thinners. Why do you think he had an LV thrombus? Left ventricular thrombus. Drug-eluting stents. So he had acute coronary syndrome. It was an LAD lesion. They took him to the cath lab. They put it in with a stent. And then they found out that in his left ventricle, he had a thrombus. Correct. No, not because of the stent. No, not rupture. LV free wall rupture is death. If you rupture your LV free wall, it's death. Huh? Staph? No. So we talked about this yesterday. What's one of the main complications that we talked about of acute coronary syndrome? What type of aneurysm? Those are the two types of aneurysms. Pick the other one. Yeah, remember one of the complications to a true left ventricular aneurysm is a left ventricular thrombus. Why? The stasis, correct. Yeah, you have akinesis and hypokinesis of the left ventricular wall. So when you have acute stasis of the left ventricle, you have an LV thrombus. This is why it's important to diagnose it and treat it, because if you don't treat the LV thrombus, what's going to happen? Not an aneurysm. Hmm? A piece of it is going to embolize to the brain and give you an embolic stroke. Does this sound familiar? Okay. So he had a well-established complication to his plaque rupture. He's got an ischemic cardiomyopathy. His ejection fraction's 20%. What's a normal ejection fraction? Over 55%. Okay? He's got obesity, polysubstance abuse with cocaine, and alcohol abuse up to 1 pint of whiskey per day. He presents as a transfer from the VA for worsening chest pain after he snorted cocaine. In the ER, he was noted to have ST elevations in leads 2, 3, and AVF on ECG, and he went into ventricular tachycardia, and he got shocked from his defibrillator. ST elevations subsequently resolved, but he was transferred to our hospital for further workup. He arrived to the CCU. He was started to having worsening chest pain, and his blood pressure is 87/55, and his ECG was as follows. What do you see? This is what we saw. Where? No. Yeah, look at V2, V3. Not so much in V4, but definitely in V2 and V3. What is the next best step? Cath, his blood pressure is now 70 over 46. What do you think is happening? Shock. What type? Cardiogenic? That's a good guess given the fact that he's having chest pain. And yeah, exactly. Maybe he has such severe LV dysfunction that he is not able to generate cardiac output. What would you expect his systemic vascular resistance to be? No, it would be high. We talked about this yesterday. It would be low if you had what type of shock? Sepsis. Cardiogenic shock, you have very high systemic vascular resistance. The body's shunting blood from the extremities to develop a pressure to protect the vital organs, the brain and the kidneys. On exam, what would you expect to see? Cold and clammy extremities because patients are vasoconstricted. So he's taken to the cath lab. Right atrial pressure is 15, right ventricular pressure is 16, pulmonary arterial pressure is 22, wedge is 20, his LVEDP is 12, and his cardiac output is 2.5. They don't give you an SVR here, but what do you think of these numbers? Are they surprising to you? Huh? Yeah, they're pretty good, actually. If he was in cardiogenic shock, what would you expect his LVEDP to be? High. Yeah, his LVEDP is 12. So, look at this. This is his ICD lead. This is the base. This is the apex. What is this right here? Huh? Aneurysm. That's his LV aneurysm. Look at the apex. Is it even moving? No. Left main, circumflex, LAD. You see a lesion right here in his LAD. But flow distally is pretty good. Left main. Look at this very large LAD feeding the apex. And look at this. What's this? Yeah. What do you mean by lesion? What's cutting it in half? What is that? Thrombus. That's thrombus, right? This is why all plaque rupture leads to coronary angiography and revascularization. Chest x-ray. Look at this. Airway is midline. He's got an ET tube. He's intubated. He's rotated. You can see the left shoulder higher than the right. Look at the airway. some mild pulmonary vascular congestion. I don't see any pleural effusion at the costovertebral angle, right hemidiaphragm higher than the left because of the liver. And what do you see here? Aneurysm, cardiomegaly. Huh? Portable. So, cardiogenic shock, heart failure with reduced ejection fraction. He had a diagnosis of heart failure with reduced ejection fraction, right? They told that to you in the stem. What was his ejection fraction? 20%. So the gentleman infarcted in 2007, got revascularized, had a LV aneurysm complicated by a thrombus. His ejection fraction was 20%. Now he's coming in with a STEMI at the outside VA hospital, inferior ST elevation MI. They sent him over, we cathed him, revascularized his RCA. He was hypotensive, LVEDP was low. Okay? So, he's status post RCA, revascularization. He was weaned off of pressors over the next 48 hours. He had a balloon pump placed. What's a balloon pump? Where is it? What part of the aorta? The descending aorta. During systole, what does it do? It deflates, reducing why does it deflate during systole? To what? It creates a negative pressure whereby, yeah, what is that called? Afterload. What does it do to afterload? It reduces afterload. Is that good for a failing heart? Good. What does it do during diastole? It inflates. Why? It doesn't give more time. No. Yeah, the aortic valve is open or closed? Closed. So when it inflates, the blood flows where? To the coronary sinus, thereby perfusing the coronaries. Do you understand why it doesn't increase coronary time? No. What increases coronary time? Reduction in heart rate. That has nothing to do with heart rate. Correct. Correct. At whatever heart rate there is. Can you beta block this guy? No. What's his blood pressure? Low. So when you're in shock, cardiogenic shock, septic shock, hypovolemic shock, you don't put any beta blockade because beta blockade is a negative inotrope. It's a contraindication to beta blockade. This is a way that you can increase coronary filling in cardiogenic shock without reducing diastolic filling time per se. Yes. Why is the blood pressure so low with the cocaine? He had plaque rupture. This is an ST elevation MI with plaque rupture. His reserve, his baseline ejection fraction was what? 20%. That's his baseline. Now he had another plaque rupture in another artery, so his reserve is already low. So you're right, cocaine is a catecholamine surge. It'll increase heart rate, it'll increase blood pressure. But this guy has a low cardiac reserve with another plaque rupture. So he's already teetering, and now he just fell off the curve. Does this make sense? Huh? So it wouldn't, I mean, it's always a factor. It's always a factor, right? Yeah, I mean, that's a good question. We'll never know. But the reality is, cocaine does what? Yeah, so what does it do to heart rate? Increases, right? So what does it do to diastolic filling time? It lowers it. For someone with an ischemic cardiomyopathy, is a good thing or bad thing? Yeah. So whatever residual coronary disease you have, it makes it worse. On top of that, causes vasospasm, right? Cocaine causes clear vasospasm. If your EF is 20%, good thing or bad thing? Bad thing. And if that wasn't enough, what does it do to your blood pressure? Increases. Well, you have no idea. You weren't there to take his blood pressure when he snorted cocaine, right? He snorted cocaine, had chest pain, had plaque rupture. By the time he got to the hospital, they saw ST elevations and he was already hypotensive. So you don't know if the hypotension was from the plaque rupture and the cardiogenic shock versus something else. Does that make sense? Mm-hmm. No. So his initial ECG at the VA showed inferior ST elevations, but then he got shocked. When he got shocked, the ST segments ended up resolving, but the initial ECG still showed the ST elevation. But your other important part of that question was he still has ST elevations in V2 and V3. What is that from? Yeah. What's the ECG pattern for an LV aneurysm? Yeah, we talked about it yesterday. Mhm. When you have an LV aneurysm, what's the ECG finding? Persistent ST elevations in the presence of Q waves. So the ST elevations that you saw is from the aneurysm he developed in 2007. Remember we went through the progression of the ECG? And remember the ST segments after the infarction should come down? When the ST segments persist, correct. No, no. Persistent, this is outside of your level, but, right? Forever, forever. Here it's a little challenging. This isn't a classic because if you look at V2, you actually see a small r, right? But if you look at V3, he's queued out. But persistent ST, I mean, those are true ST elevations. Those are true ST elevations. But the reason why you didn't see anything in the LAD was because he was revascularized in 2007. These ST elevations are from that. Okay? All right. No, no. Huh? Why is the amplitude so low? I mean, it could be many different things. What causes low amplitude? No. Anything that increases the distance between the ECG electrode and the myocardium. Huh? Fat? He's obese. So that's one. What else? Fluid, a large pericardial effusion. That can be low voltage. Air, chronic COPD with the hyperbarrel chest. What's that? So ECGs are important. It's like any other test, you need a prior to compare, right? So I wouldn't make too much of that. Huh? Did he fracture his left clavicle? I'm not sure. I'm not sure. But we got to keep going. Heart failure. So over 5 million Americans have heart failure. Incidence rises with age up to 12% amongst greater than the elderly. More than 1 million hospitalizations with a primary diagnosis. Rehospitalization rates are 20 to 25% within 1 month. It is incredibly difficult for us to keep these patients out of the hospital. As a high mortality, particularly amongst older Medicare patients, long-term studies in the Framingham and Olmsted cohort suggest a 50% 5-year survival. The risk-adjusted 1-year mortality is approximately 30% after hospitalization. Medical management of heart failure continues to rise in the United States, and the prevalence of heart failure increases as we get older. So you can see the incidence clearly increases with age. Like most things, that's a syndrome. Where have we seen syndrome before? Acute coronary syndrome, correct. Syndrome. Classically, heart failure is an inability of the heart to supply blood in a manner to meet the metabolic demands of the body. It can occur at the expense of higher filling pressures and it's secondary to issues in the ventricular filling or ejection. Filling or ejection. If it's an ejection problem, what do you have? HFrEF. If it's a filling problem, you have HFpEF. Correct. There are a lot of diagnostic tests that are supportive when making the diagnosis. Okay? This is not the same as cardiomyopathy. Cardiomyopathy is like MI. What does that even mean, cardiomyopathy? Ischemic cardiomyopathy, non-ischemic cardiomyopathy, dilated cardiomyopathy, hypertrophic cardiomyopathy, right? So as you're advancing through your training in medical school, you're going to realize that you have to be very specific in the terms that you're using. Oh, Frank-Starling, you love this, I know. It is very difficult clinically to measure volume. How do I measure volume in the left ventricle? We can't. Even in the cath lab, I can't measure how much blood is in the volume. So we use pressure. The higher the pressure, the greater the volume. Pressure is not the same as volume. Okay? You can substitute stroke volume for other measures of cardiac output. And everything in this is related to preload and afterload. It is critical for us to figure out the cause or the etiology of the patient's heart failure. Look at all the different things that we can use. Age is the greatest risk factor, by far and away. Look at all of the risk factors: smoking, sleep apnea, cholesterol, CKD, albuminuria, homocysteine, anemia. There's genetic risk predictors, toxins, and obviously the major: age, being male, hypertension, acute myocardial infarction, which I just told you the implication here is plaque rupture, acute coronary syndrome, valvular heart disease, and obesity. So machine learning is critical right now in the diagnostic testing, but not really the risk factors. No. Remember, 1/3 of individuals with plaque rupture have no risk factors, right? A really cool niche in artificial intelligence right now is to take a look at someone's ECG and predict future incidents of heart disease, cardiomyopathy, sudden death, arrhythmias, far surpassing our clinicians' interpretation. There's tons of, uh, like, I think the Mayo Clinic right now is far above and beyond what anyone is doing in terms of ECG interpretation. Their AI algorithm is phenomenal. So, myocyte injury and stress and incidence of heart failure. So, myocyte injury is central to the pathogenesis of heart failure. Neurohormonal model. Neurohormonal model. If there's one thing I want you guys to walk away with, is that when I tell you that heart failure is a syndrome, it's a neurohormonal issue. Okay? Models of heart failure must explain the initial injury and progression of injury. Okay? The mechanism of injury dictates treatment. Plaque rupture, early revascularization. What about chemotherapy? Anthracycline toxicity, another cause, right? There's a whole slew of non-ischemic causes. Takotsubo or stress-induced cardiomyopathy. Dilated alcohol cardiomyopathy. Yes. What do I mean by neurohormone? Fantastic. So you have myocyte injury and it causes increased wall stress. This increased wall stress leads to a sequelae of events that are hormonal in nature. Ventricular remodeling. What do I mean by ventricular remodeling? Yeah. So if you're talking about a pressure problem, what's the remodeling? Concentric hypertrophy. If you're talking about a volume problem, eccentric hypertrophy. And this occurs through three major pathways. You have to know these major pathways. One pathway is catecholamines. Catecholamines. Does the catecholamine pathway increase or decrease? Increase. Increase. You have a sympathetic surge of catecholamines in HFrEF. Renin, angiotensin, aldosterone. Is this familiar? Remember, angiotensinogen goes to angiotensin 1, goes to angiotensin 2. What's angiotensin 2? Vasoconstriction. Vasoconstriction. Aldosterone. What does aldosterone do? Yeah, sodium and water retention. Do you guys know why these are activated? Oh, it responds to what? What's the problem with the blood pressure? Correct. So assume I'm a caveman in BC times. I'm out in the field, I'm hunting and gathering, and then I have plaque rupture. Chest pain up my jaw, down my left arm. I start getting hypotensive. Cath lab. Yes. So how am I going to survive? Adrenaline goes up, catecholamine goes up, I become tachycardic, renin gets activated, aldosterone gets activated, I'm hypotensive, and now all of a sudden volume comes in, preload goes up, adrenaline goes up, cortisol goes up, and I have a blood pressure. And I get myself back to my caveman family, and ultimately I die of the sequelae of heart failure. But these are really critical primitive hormonal pathways, right? In the advent of the cath lab and modern medicine, now we have the opportunity to survive, revascularize, but these pathways are still activated. And so you want to prevent catecholamines, you want to prevent aldosterone, and you want to prevent renin angiotensin. Because the last thing you want is volume and afterload in the setting of plaque rupture. Does this make sense? So this neurohormonal cascade is really hormonal driven by these three main pathways. Everything we do in the management of heart failure is block these hormonal pathways. Because the long-term sequelae of these pathways are very detrimental. They get volume overloaded, and then they come in decompensated. Okay? So, vasoconstriction, sodium retention, sympathetic activation. We want to block every single one of those pathways because it leads to apoptosis, fibrosis, stress, and ultimately altered gene expression. I'm not going to go over this. You guys should know this or will know it in the near future, but understand the renin angiotensin aldosterone system and how they cause vasoconstriction and volume retention. This is telling you you can block angiotensin 1, angiotensin 2, ACE. All of those things are pathways in which we can block them. Remember, ACE inhibitors increases the concentration of bradykinin, leading to cough and possible angioedema. Sympathetic activation. What are the 3 drugs with proven mortality in HFrEF? Metoprolol, succinate. Number 2, carvedilol. Number 3, bisoprolol. Bisoprolol. These are the 3 proven beta blockers in randomized controlled trials. If you have HFrEF, those are your 3 options. Why? They block the sympathetic activity. That's one of the neurohormonal pathways that's augmented in heart failure. Guess what? Beta blockers reduce the activation in a dose-dependent manner. Bless you. Let me repeat that. Listen very carefully. Beta blockers reduce the activation of the sympathetic stimulation in a dose-dependent manner. So do you want your patients on a low dose or a high dose? High dose. Why? Yeah, why were you thinking low? If a low dose blocks the sympathetic pathway in a minor way and a high dose blocks it in a major way, which one's going to confer better mortality? Oh, it blocks the sympathetic activation in a dose-dependent manner. So if you can get them on a high dose, what do you think their sympathetic hormone in the circulation is going to be? Low. Good or bad for heart failure? Excellent. It's excellent. Okay? So, like I told you, the sympathetic system is providing support for the failing heart in the short term. But survive today, pay the piper tomorrow, right? Norepinephrine levels are circulated in chronic heart failure patients. They develop changes in the beta receptor subtypes. Alpha receptors contribute to vasoconstriction, and norepinephrine contributes to apoptosis, myocardial ischemia, arrhythmia, and tachycardia in heart failure. Remodeling. God, I hate this term. Remodeling. What does that even mean? Concentric, eccentric hypertrophy, right? So drop the volume, drop the sodium retention, and drop the afterload, right? Renin and angiotensin 2 is a profound vasoconstrictor. Block it to prevent concentric hypertrophy. Block sodium retention, block water reabsorption to reduce the volume, reduce preload to prevent eccentric hypertrophy. Once you have concentric and eccentric hypertrophy, this is what gives you large LV mass due to a pressure overload, and dilated, you get thinning of the myocardium and dilated cavity. This is due to a volume overload. This is from my pathology textbook. when I was in medical school, Robbins, right? So, eccentric versus concentric hypertrophy. What do you think that is this ventricle stiff, compliant? No, this is a very non-compliant ventricle. Very hypertensive concentric left ventricle here. This is cor pulmonale. Very concentric right ventricle. The right ventricle pumps into the pulmonary circuit, right? The pulmonary circuit pressures are very low. So it was never meant to deal with very high pressures. Cor pulmonale, you'll get to later on, I think. Cor pulmonale is right-sided heart failure due to a pulmonary issue. The most common side of right-sided heart failure is left-sided heart failure. But sometimes you have right-sided heart failure that has nothing to do with the left side. It has to do with a problem with the pulmonary. That's cor pulmonale. So, remodeling, right? This is a normal heart, and look at the dilated cardiomyopathy to your right. Concentric, eccentric hypertrophy, we've talked about this. These are the things that you're trying to prevent long term. There has not been a change in the management in HFrEF for many, many years. The last 5 years have provided a lot of excitement, new therapies. To your left, you can see, for the most part, we had so many targets to block in terms of the neurohormonal pathways. The catecholamine pathway, renin-angiotensin pathway, and aldosterone pathway. For years, that's all we would do. We would target those 3 pathways. What's that? No, there's not a way to target all of them at the same time, unfortunately. But this is why we use beta blockers, and we use ARBs, and we use aldosterone, right? Mineral corticosteroid inhibitors. But for the first time, we have found a hormonal pathway that is actually beneficial. What is that? Natriuretic peptides. What are the natriuretic peptides? Tissue stretch, myocardial stretch, correct. Yes. They vasodilate and causing what's that? No, not parasympathetic. No. Huh? How? Yeah. Yeah, it's a diuretic. To myocardial stretch, not only does it promote diuresis, but it's a vasodilator. Is vasodilation a good thing or a bad thing? It's a good thing. Is diuresis a good thing or a bad thing? It's a good thing. So would you want low levels of natriuretic peptide or high levels of natriuretic? Ugh. What's that? Would you want to augment natriuretic peptides or inhibit? Augment. Augment. So the traditional therapies have always been to inhibit the negative hormonal pathways. For the first time, we have a hormonal pathway that is beneficial that you want to augment. Huh? Okay. So there are multiple different types, BNP, ANP. BNP is cleaved into BNP and NT-proBNP natriuretic peptides, vasodilation, natriuresis, renal vascular effects, inhibition of cardiac hypertrophy, and inhibition of renin aldosterone synthesis, all of the things that you guys mentioned. They're released as a response to increased wall stretch, right? Wall stretch. Net effect is to counteract sympathetic and neurohormonal pathways and to reverse remodeling. Antidiuretic hormone. Vasopressin operates via V1 and V2 receptors. Decreased cardiac output stimulates ADH secretion from the pituitary gland. Water excess gives you hypervolemic hyponatremia, and hyponatremia is associated with increased mortality in heart failure. Less death, more increased mortality. Mortality is bad. Remodeling, okay? This is what we're trying to prevent long term. Involves multiple myocyte alterations, including myocyte hypertrophy, cell death, apoptosis, myofibroblast proliferation. The heart becomes less elliptical and more spherical. The ejection fraction reflects remodeling in systolic heart failure, and other measures of LV volumes are also relevant. The goal of heart failure is to reverse remodeling. So, differentiating right and left-sided heart failure. So, the right ventricle morphology is very different than the left ventricle. You guys already know the most common etiology of RV failure is LV failure. But obviously, other causes of RV failure exist. Chronic pulmonary embolism, pulmonary hypertension, pulmonary fibrosis, chronic lung disease such as pulmonary hypertension, and isolated RV infarction. So, signs and symptoms. Obviously, right-sided heart failure has anorexia, lower extremity edema, ascites or abdominal distension, and increased jugular venous pressure, either from a left-sided heart failure issue or cor pulmonale. But if you have the involvement of the left side, that causes cough, orthopnea, dyspnea. Why? Why? Why would they lose weight? Huh? Some of it is appetite, but there's also heart failure. It increases expenditure, increases catabolic drive. Yeah. You guys know what failure to thrive is? What is failure to thrive? In an adult. No, in an adult. Yeah. They get bitemporal wasting, low muscle mass, cachexia. Like you'll look at them and they may have a belly, they may have ascites, but in their extremities, they're incredibly skinny. Yeah, end stage heart failure, rheumatic heart disease, malignancy, metastatic cancer. There's a whole slew of different things that can give you this. So, heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So, heart failure with preserved ejection fraction, this is a filling problem. Their ejection fraction is normal, but there's a compliance issue. And so when the left ventricle can't expand properly, it cannot accept blood properly. This is a stiffened, non-compliant ventricle. Okay? Age. So as you age, you guys, not you guys, you're still young. I like to say you guys are still under the warranty of youth, right? When you get to my age, the LV begins to stiffen a little bit. You know, diastole is a very dynamic part of the cardiac cycle. What's the advantages of having a compliant left ventricle? Smooth blood flow from, yeah, exactly. When you have a compliant left ventricle, there's nothing passive about diastole. If you can imagine just sitting in the left ventricle and you're in diastole, that left ventricle expands, creates almost like a negative pressure, forcing the mitral valve open and just beginning to suck blood from the left atrium to the left ventricle. It's a beautiful thing. But as you lose the elasticity of the left ventricle, you lose that gradient, right? Concentric hypertrophy, one of the sequelae of it is a concentric ventricle is less compliant. Long, long-term hypertension causes left ventricular hypertrophy, right? So age, prior myocardial infarction, chronic hypertension, all of these things can cause heart failure with preserved ejection fraction. Well, this represents the majority of heart failure patients. In my practice, when I get sonograms on my patients, diastolic dysfunction, they're 70, 75, they have a less compliant ventricle. Okay. It's, it's just a sequelae of aging. Some of them, however, will come into the hospital volume overloaded. Okay? And then you're managing their heart failure with preserved ejection fraction. So this is characterized by true vascular and myocardial dysfunction. Survival is better than HFrEF, but it has not changed significantly in the last 20 years, right? Beta blockers, ACEs, ARBs, aldosterone. They play fantastic roles in HFrEF, but in HFpEF, no. There hasn't been any benefit. Yes, so there's data coming out with natriuretic peptides, and then there's another new class that's hit the news. I don't know if you guys have heard, SGLT2 inhibitors. Yeah, there's a new kid on the block. Probably not ready for you guys prime time, but it's one of the excitement in HFpEF that we're beginning to use in these patients. Okay? Here's the thing. How do you diagnose heart failure? Huh? No, what are you trying to say? I'm so so you're right. You need an echocardiogram to differentiate between HFpEF and HFrEF. You are correct. But the question is, how do you diagnose acute decompensated heart failure? Symptoms. What symptoms? Not chest pain. Dyspnea, edema, cough, orthopnea, right? Symptoms of volume overload. Acute decompensated heart failure is a clinical diagnosis. You can if you want. Physical exam. Acute decompensated heart failure is a clinical diagnosis. If they come in volume overloaded, heart failure. That's a transesophageal echocardiogram. All you need is a transthoracic echocardiogram. Remember, the left ventricle is more anterior. The left atrium is posterior. So all you really need is a transthoracic echocardiogram to differentiate between HFpEF and HFrEF. But the diagnosis of acute decompensated heart failure is a clinical diagnosis. It all comes back down to your clinical exam. Yes. No. No. I will tell you what those symptoms are. I will tell you. There's only a few things you need to know. Okay? I will get to. I will get to. Look at this last point. Echo is necessary to differentiate HFrEF from HFpEF. But how do you diagnose acute decompensated heart failure? Clinical symptoms. If I were to test you, I would ask you that question, and answer choice number A would be echo. And you would be wrong. I'm not a test writer. But if I were a test writer, that's what I would do. So, you're already guessing what I'm about to talk about. Remember, who was there yesterday at the IM interest group? This is what I was referring to. JAMA. The Rational Clinical Exam is a series of articles that very, very smart people started to ask the question, what are the 3 things I need to know when someone's short of breath that this is acute decompensated heart failure? What are the 3 things I need to know if a patient comes in with abdominal pain and it's appendicitis? What are the 3 things I need to know in a patient coming in and I think this is pulmonary embolism? Chapter after chapter after chapter of very well validated clinical signs and symptoms that all you really need is 2 or 3 things. Remember in ICM, I started telling you guys that you have to start thinking what questions to ask. What is relevant? Well, these articles are telling you what is relevant. So you have to look at the title. The question that the article is asking is that you are in the emergency room seeing a patient who is short of breath. How do you know it's acute decompensated heart failure? Look at this. So they use likelihood ratio, and likelihood ratios here as a clinician is critical because the equation of likelihood ratios include sensitivity and specificity. So a positive likelihood ratio, you want a high number. A negative likelihood ratio, you want a low number. So for me, anything over 5 is really good as a clinician. But look, just by talking to the patient and taking a history, a good history, look at the positive likelihood ratio, 4.4. Just clinical judgment from your history-taking skills is pretty good. Remember yesterday I told you all you really need is a good HPI, a broad differential, and pertinent review of systems. That's 90%, right? So look at the symptoms. Right? Symptoms. Anything in the symptoms is under 5. Interesting. Orthopnea, PND, all this stuff. They're not great, right? Shortness of breath. Okay, what's your differential for shortness of breath? 10 pages long. You are correct. You are correct, actually. Anemia gives you shortness of breath. Pleural effusions give you shortness of breath. Malignancy gives you shortness of breath. Bronchitis, pneumonia, TB, shortness of breath. Asthma, shortness of breath. Anxiety, shortness of breath. Yeah. So how can you say, oh, shortness of breath, heart failure? No. But look, the money is in your physical exam. Now, remember yesterday we talked about Bloom's taxonomy? This is forcing you up the pyramid, right? Look at the highest positive likelihood ratio is in S3. Can you tell me why an S3 is so good for acute decompensated heart failure? Huh? Why? Why'd you say volume overload? That doesn't make sense to me. Explain it. See, remember, I need you to go up. What part of the cardiac cycle? Diastole. Early or late diastole? Early. What's happening in early diastole? Rapid filling. So, mitral valve is open. Blood is coming from the left atrium to the left ventricle, and what's happening? No, 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 no. It's not filling up fast. What is the S3 sound? No. You said volume overload. So fundamentally, huh? It's not more filling. It's there's blood in the ventricle. It's not an empty ventricle. There's blood in the ventricle. So it's blood on top of blood. It's blood hitting blood. And S3 is when the left atrium is trying to fill the left ventricle that is not empty. So if the left ventricle already has blood in it, what do you think the end diastolic volume is? High. What do you think the wedge pressure is? High. So if you have an elevated wedge pressure and you hear an S3, that dyspneic patient in the emergency room is short of breath because it's a left-sided issue. It can be HFpEF from a stiffened, non-compliant ventricle. It could be HFrEF due to an ejection problem. You don't know. You need an echo to differentiate between the two. But that patient in the ER that's short of breath is short of breath because of a left-sided volume overload. That's why if you hear an S3, forget it. You're done. Not an S4. Yeah, what's the fourth? Yeah, garbage. Now notice JVD, hepatojugular reflux. What is that compared to an S3? Still good, but lower. It's about 50% less, right? Why? Why isn't it as good? It's less specific. We just talked about core pulmonale. All of the etiologies of core pulmonale will give you signs of right-sided heart failure. JVD is a sign of right-sided heart failure. Hepatojugular reflux is signs of right-sided heart failure. But you guys already know that the most common cause of right side is left-sided heart failure. So it still makes it pretty good, but it makes sense that it's less specific because there's a greater differential diagnosis. So when I see patients in the emergency room for shortness of breath, guess what I look for? An S3, JVD, and a hepatojugular reflux. Leg swelling. Where is leg swelling? Look how low it is. Why? Give me your differential diagnosis for leg swelling. Varicose veins, trauma, DVT, cellulitis, nephrotic syndrome, cirrhosis, portal vein thrombosis. Oh, and heart failure. Does this make sense? I'm showing you ways to go from remember to analyze, understand, evaluate. When I tell you guys dissect this information, I need you to take a look at the topic and dive deep. These articles really, really were transformative for me as I began to hone in my clinical skills. But you can see, it's all based on pathophysiology, right? Oh, and all of these articles online, free. Crazy. I don't know if UWorld or, huh? No, if you Google the Rational Clinical Exam from JAMA, one of the sites, it's a free PDF. Yeah. Look, if there's one diagnostic test, if there's one diagnostic test that is helpful for you, chest x-ray. Chest x-ray. Why? Why is a chest x-ray so good? Pulmonary vascular congestion. Why is that so good? Because if you're short of breath and you have an elevated wedge pressure, you're going to have pulmonary vascular congestion. Simple as that. So if the chest x-ray looks wet, it's a great sign, right? For the clinician, right? But you'll see why, you know, it's hard for me to tell you what's happening in real life. These patients are getting ABGs, CAT scans. They're throwing 100 tests at these patients in the ER. All you need is just one or two things. That's it. It's just pathophys. That's it. Okay, low voltage. This is low voltage. What are the three things that cause low voltage? Increased tissue, fluid, air. Air, hyperbaral chest and COPDers, pericardial effusion, obesity. Three things. Hemodynamic profile of heart failure. Warm and dry. They're very well compensated. They're warm, well perfused, dry, euvolemic. That's the goal. Warm and wet. They're well perfused, but they're volume overloaded. These are the common presenters that come in with volume overload, right? Profile C, cold and wet. Bad sign. Bad sign. They're volume overloaded and they're cold. So their cardiac output is low. Very difficult to manage. Cold and dry, don't worry about. Okay. So once you diagnose acute decompensated heart failure, you need very little. EKG, obviously, minimal, non-invasive. Echocardiogram, you already told me you need an echo. For the diagnosis, for the differentiation. You do not need it for the diagnosis. Obviously, if you do an echo and their EF is 15%, well, the question then is, do they have underlying coronary disease? Then you take them to the cath lab and figure out what their coronary anatomy is. Cardiac MRI is really important because a cardiac catheterization only takes a look at the blood supply. A cardiac MRI actually takes a look at the myocardium, at the tissue, right? Like cardiac sarcoid, cardiac amyloid, the infiltrative cardiomyopathies, a cardiac MRI would be beneficial. A cardiac CT is a CAT scan of the coronary arteries. So if someone comes in and they're only 20 or 30 years old and you're not thinking about coronary disease, it's less likely on your differential, you can do a CAT scan of their coronary arteries. Or you can do a PET CT, which is good for sarcoid. Finally, stages. Heart failure class stages. New York Heart Association class 1, no heart failure symptoms. Stage 2, They have symptoms with some ordinary activity. Stage 3, less than ordinary activity. And stage 4, at rest. So this is a way that we classify heart failure in our clinical practice. And it's also a prognostic indicator. Okay? The problem is that there's very little reproducibility. You interview the same patient by different providers, they get different answers to those questions. Okay? The point of medical therapy and diagnosis is to get them to as low of a stage as possible. You want them euvolemic so they're able to exert themselves and have a high quality functional daily routine. So this is the pathophysiology of heart failure, HFrEF and HFpEF. Clinical diagnosis. Tomorrow, we will dive into the management. Any questions? Any questions about the neurohormonal model? Okay, thank you guys. Sure.